أعوذ بالله السميع العليم من الشيطان الرجيم من همزه ونفخه ونفسه بسم الله الرحمن الرحيم نحمده ونصلي على رسوله الكريم أما بعد. Welcome again, dear viewers, to Medicine and Islam, a program sponsored by Sharjah Television that features topics relevant both to the field of medicine as well as to the great religion of Islam. Alhamdulillah Rabbil Alameen. As you know, diabetes is one of the main problems here, not only in the Emirates but throughout the world. We've done many programs on diabetes. In fact, we've done 9 previous episodes. Today is part 10 in our series on diabetes in the UAE. However, you might find it interesting that the topic today is called An Introduction to Type 1 Diabetes. And you may say, well, if you've done 9 episodes, how can episode number 10 be an introduction? Well, that's because before now we did not have a really good specialist in this area. We had very good experienced physicians that came on and shared their experiences with us. But now we have with us Dr. Ejaz Yasmeen. Assalamu alaikum.
Walaikum salam. How are you?
I'm very good. Dr. Ejaz is a specialist in internal medicine and in diabetology at BELHOUL Specialty Hospital in Dubai in the Emirates. He was with us during our Ramadan special talking about the implications and the factors that determine whether or not diabetics can fast. And we were so impressed with him that we told him that when Ramadan was over that we wanted him to come back and really kind of walk us along this road of dealing with diabetes, because he is a specialist in this area. And this is a problem. It's not going away. It's just getting worse throughout the world. Now, Dr. Ejaz, could you first please tell our viewers something about your specialty and what exactly is diabetology?
I'm very honored to be here again on this podium, and it is really an honor for me to be here. Well, regarding my specialty, I'm basically an internal medicine specialist, and I have done my post-graduation in diabetology. So diabetology is a branch of endocrinology. We particularly look in the patients who have diabetes. Our aim is to catch them early and treat them full-fledged.
I see. So it is a branch of endocrinology?
Yes, definitely.
Okay. Now, when you're in your training for diabetology, do they also deal with like thyroid problems?
Of course. We deal with thyroid problems, we deal with problems related to ovaries, we deal with obesity, we deal with dyslipidemia, and we of course deal with the diabetes.
Right, okay, because they're all interrelated,
yes,
isn't
of course,
it?
definitely.
Yes, absolutely. Now, what is the definition of type 1 diabetes, and what percentage of diabetics actually have this type of diabetes?
See, if we see the scenario in our place in the UAE, we are unfortunately the leaders for the wrong reason. The prevalence of diabetes in UAE, as per the latest data, is around 19.8%. That means if we are 5% here, one of them will have diabetes, and if we see the pre-diabetes, where the risk is high, we have again 20 to 30%. That means every second to third person will have either diabetes or will have a pre-diabetes. Regarding your question of type 1 diabetes, it is mainly seen in young adults and then young children. Okay. And the percentage is not as much as type 2 diabetes. We may have around there is no clear data about the prevalence of type 1 diabetes, but it may be around 5 to 6% of the patients may be having type 1 diabetes.
Right.
Type 1 diabetes literally means it's an insulin-dependent diabetes mellitus. That means our body is not producing insulin.
At all?
At all. Okay. It's basically an autoimmune disease where there are antibodies formed against the cells which produce insulin from the pancreas. These are called the beta cells. So how it happens, basically what happens in these patients, they have a genetic susceptibility. Either they have a first degree or a second degree relative who has it. And with this genetic susceptibility, any insult, maybe infection, maybe viral infections, maybe suppose we are giving a child the cow's milk at an early age. That can be a reason why he can have this. All infections with this underlying genetic susceptibility can lead to an autoimmune destruction of beta cells, which will manifest in a florid type 1 diabetes.
And these younger adults and children, do you find it more prevalent in children that were not breastfed versus those
Definitely.
that were?
Those who are breastfed, they say there's a protection against. But those who get cow's milk at an earlier age, or those who have vitamin D deficiency, they are more liable to get type 1 diabetes in the coming years. So much so, if you have a twin, a monozygotic twin, the lifetime risk is around 30 to 40%. of the second person to get the type 1 diabetes.
Okay.
But in type 2, it's almost 100%. If one monozygotic twin will have, the second is definitely going to have the type 2 diabetes.
Subhanallah. Ajib. That's interesting about the cow's milk, and there is still a genetic component.
Definitely, definitely. It is in the genes. It's in the genes. There are a lot of genes which have been identified. Okay, it's genetic. If a parent, suppose a father has it, the risk of the offspring is 3 to 8%. If the mother has it, it is 4 to 5%. But when both have it, it's around 20%.
Subhanallah.
So it is an additive effect which occurs.
And even though it is autoimmune, sometimes there's a trigger.
Definitely, definitely.
Like infection,
Infection, yeah, which
other
promotes,
insult.
Yeah.
Subhanallah. Unbelievable. But there's the pancreas itself is the beta cells don't produce any at all.
No, this is a definition of type 1 diabetes.
Okay.
Type 1 diabetes, there is absolute deficiency of insulin.
Okay.
Okay,
Absolute.
and absolute. In
Meal to meal.
type 2, there is relative.
Okay.
Okay,
Right.
so this is the difference.
I understand. Now, of course, the next question that I'm going to ask you, it's not fair to ask you this question and ask you to give us a short answer, because this question could require several episodes to thoroughly answer properly. That's why you're going to have to keep coming back from time to time to give us more information.
Yeah.
And this question, it sounds like a simple question, but it's a vast question, and that is, what is your therapeutic approach to the treatment of this disease?
See, it's a disease. If we have type 1, we have to take certain factors into consideration. Firstly, we have to take the family into consideration, how they will approach the disease. Because when you have a child who is 2 years, who is a neonate, who is 1 year, what you can explain to him about type 1 diabetes? One who wants a chocolate, another wants a drink. You can't say to them, don't eat it. So it's a multi-system approach, where you have the doctor, you have the diabetic educator, you have the nurse, you have the family, and at last you have the child who has the disease. Okay, if it is a child, say 12 years, 14 years, 15 years, we can start with the child, but it is a complete network of the systems which has to work.
Okay. So it's like a team approach.
It's a team approach for type 1 diabetes.
Okay. Now, how often do you actually see it in infants and very small children, opposed to adolescents or teenagers?
In children, the last patient I saw, she was 4.5 years of age, and she came with a blood sugar of 820.
Subhanallah.
Okay, and she was losing weight, and she was eating everything in the house. She was always near the refrigerator eating food.
4.5.
4.5 years, yeah. I've seen even 2 years, I've seen 3 years, but this is the latest I've seen, probably it was last month.
Okay.
And we directly started her on insulin, and she was doing absolutely wonderful.
Ajib, very good. Now, and this is connected to this. The next question is, what are some of the problems that you have to confront when you're trying to treat these patients? Like, for instance, a lot of people have phobias and fears of needles.
Yeah, definitely.
How do you deal with that?
To be more honest, when I have a patient who needs insulin, I first demonstrate it on my body. Believe it or not, the first thing is I inject normal saline and show the parents it's not that painful. Make them try it. Because now with the latest developments, we have wonderful pens with small hypodermic 5 mm needles, which are very thin, and we have to demonstrate on them. Definitely the phobia is there, but because the parents say, if a patient receives insulin, he's going to die. Some say he's going to turn blind. Some say he's going to lose a leg. But on the contrary, it's opposite. If you give them insulin early, manage their complications, treat their blood sugars, they will have a wonderful, rosy life.
Subhanallah. Now, with regards to the insulin itself, of course, I was going to ask you about the different delivery systems. Obviously, the new flex pen and things like that is what you're referring to, which is so easy to use, right? What about the availability? Do you find in poor people that sometimes have difficulty?
In our country, we have around 80% people are insured. I'm talking about our Emirates, Dubai.
Right.
So there is no paucity of the pens. You can purchase them because they're covered by the insurance.
Okay.
But those people who don't have insurance, who are poor, it's quite an expensive affair for them.
Yes.
So we can resort to syringes and old system.
Okay. Now, some of your training was in India, correct?
Yeah, yeah.
Now, what was your experience there with the type 1 diabetes that were poor?
Well, to be more honest, earlier they used to use bovine injections, okay? Bovine from the cows, porcine from the pigs. Okay? Right. And because it was very cheap, okay? And now with the latest development, we have the recombinant insulins. if I say in the rural areas, 99% will use syringes.
Okay.
Okay. Only 1% can afford this flex pens or other delivery systems.
Okay.
In the urban setup, maybe around 20 on pens and 80 on insulin. But alhamdulillah, in this setup in our Emirates, we are covered by insurance. A lot of people are covered by insurance, so it should not be an issue. But if you give them the delivery system, it's much better than the conventional syringes.
This reminds me of, I'm just a little bit older than you. This reminds me back in the late 60s and early 70s when I was in medical school. When during that time they were still using porcine and bovine. Most of the instruments coming from pigs, from canteen, and there was not a lot of options as to other types of insulin, and they were expensive. The other ones. And some Muslims would say, man, I can't take that insulin.
It has been Allah and them.
Yeah. But now, alhamdulillah, we don't have that problem anymore.
No.
But in some of the rural areas, you still see in India, perhaps.
Yeah, that's still this practice is going on.
So this is the option they have.
Yeah.
Okay, very good. And that's interesting because, as I understand it, for the most part, in India, most of the animals are slaughtered by Muslims. So so perhaps even the cow is halal, perhaps.
Of course.
Very good. Now, I have a experience I'd like to share with you, and I want your opinion as to what happened. I have a diabetic pharmacist I asked this question to, and she gave me her opinion. I want your opinion, because I'm sure it happens to a lot of people. That means diabetics cannot live all the time in one place. They have to travel, and they have to go to other parts of the world and carry their insulin with them. And sometimes that presents a problem. Now, I recently went to the States, and I had some difficulty maintaining my insulin at the desired temperature, which required refrigeration. And the flight from here to the States nonstop is 15 to 16 hours. Okay, fortunately on the flight I was able to get it refrigerated, but within the domestic flights they did not allow that. And my question is, at what temperature does the insulin become unstable? Because I know it is a sensitive to heat sensitive, right?
Yeah.
Okay.
The thing is, if you are using syringes and vials, you have to keep them at a temperature of 3 to 8 degrees centigrade. Okay. That means not in the freezer, but outside the freezer you can keep them. If you are using syringes and vials.
Okay.
But if you are using the modern delivery system, less than 25 degrees centigrade you can carry them. Okay. It should not be more than 25. Okay, you can carry them easily. And nowadays you can use an ice pack or something. Keep it, and even if you are traveling for a longer distance, I don't think it should cause any problem. Okay. Recommendations are it should not be more than 25 for more than 24 hours.
Okay, not more than 25 degrees centigrade for more than 24 hours.
So suppose if you say the weather out here 40, 45, I think it will not work.
Yeah, it'll be. And how do you, if you look at it, for instance, even with the flex pen, you can actually see the insulin. How can you examine the flex pen and see
remember the insulin is clear.
Okay, here we go.
If you just shake it, you see some particles are this. Okay, that means something has happened. The sites are saturated, the zinc sites are saturated. And it's not.
It should be perfectly clear, just like water.
It should be clear.
Okay, you shouldn't see any cloudiness.
No
particles.
No particles. No.
Okay, and that's when you have an idea. This is what I was told as well, because what happened was that I noticed with the long-acting, it was a bit more sensitive than the short-acting to this problem, and I actually eventually had to discard the long-acting, and as soon as I did that, the blood sugar started to come down, because it wasn't coming down. And I think and you correct me, the long-acting, the indicator of how effective that is the fasting blood sugar.
Of course. Whenever you're using a long-acting, say Lantus or other one, the Detemer, it only controls your fasting.
Right.
So whenever you have to titrate the long-acting, you have to look at the fasting.
Right.
Okay. Other one are the short-acting, because if you see our pancreas, the normal thing is it secretes some insulin, baseline insulin, whether you eat or not, whether you sleep or whatever you're doing. A level is there always. And when you take a breakfast, it jumps up like this. You take a lunch, it spikes. And you take a dinner, it spikes. That is the reason why we recommend whenever you want to put a type 1 on insulin, it should have 4 insulins. One will be the basal, the long-acting, which will cover him for the whole time. And 3 short-acting.
For your meal.
One for breakfast, one for lunch, and one for dinner.
Absolutely.
If you skip your lunch, don't take it. If you skip your dinner, don't take it. That is, we want to mimic the natural physiology of the body by giving 4 injections. This is called the basal bolus regimen.
The basic, I understand, and that's the regimen I'm on. But the problem that I experienced was that the fastings were high.
So you have to increase your Lent as a long act.
And I kept increasing, and then I realized that perhaps had become affected by the heat. And then when I discarded that, then
the sugar started coming down.
So people have to be careful about that.
Of course, about the storage.
Okay,
about how they use it, the technique. They should not inject any air. They should see when they are doing the injection, they should first make a bubble. One bubble should come out. That means the insulin is at the tip of the needle. Okay, so they're the correct technique. One, correct. There should be there should be no air. Two, and third is the storage.
And how do you get rid of that bubble? Because sometimes even in the flex pens, you see a small bubble.
So the best thing is you should waste 1 or 2 units. See them coming out.
Okay, and let the air come out with it.
Yeah. It is better to be safe than sorry.
So discard.
1 or 2 units.
In order to get the bubble out.
Yeah.
Okay. Because if you get air, then you're not getting insulin.
Yeah.
I understand. Very good. But here again, just for our viewers and for myself, 25 degrees more than 24 hours.
Yeah, it will not be denatured. It will not be denatured. But there should not be extremes of temperatures. Okay, so suppose you are telling me at 50 degree, 45 degree. See, if we see the subtropical region, it should be around like that.
Okay. Now, the last and most importantly, actually, complications. What do you see with type 1 diabetes?
The most important complication is hypoglycemia, which can be a killing one. Okay, we define hypoglycemia when the blood sugars go less than 70 milligrams per deciliter. Okay, and hypoglycemia has to be monitored. Okay, if somebody gets hypoglycemia, it is to be corrected. Don't give them 3 or 4 glasses of juices. Just half a glass of juice, or alhamdulillah 2 dates. It contains enough sugar to get him back to normal. One. Second thing is, if the hypoglycemia is not arousable, you have to give him some injectable, and you can have to send him to the hospital for observation. Okay,
so if the state of consciousness is
affected, you can
that means they're really low.
Yes.
And that's dangerous.
That is very dangerous.
Okay.
And other complications, if long-standing diabetic, they can affect their eyes, they can affect their kidneys, they can affect their nerves, which is a long-standing. It takes 10 to 15 years for the complications to occur. And the most important complication in type 1 is diabetic ketoacidosis.
Okay.
When there's acid in the blood, because what happens, the sugars go high, there is no insulin to take it inside the cells.
Right.
So the sugar is too much in between the cells. It becomes a hyperosmotic state, and the patient becomes dehydrated. And body does not use glucose; it uses other forms for energy, and these are converted into acids.
So with the type 1, if they eat and forget to take the insulin,
that is harmful.
They can get ketoacidosis. And if they take the insulin and they forget to eat, they get hypoglycemia.
These are 2 extremes of type 1 diabetes.
So there's a direct correlation between eating and taking your insulin.
Yeah, definitely.
Okay, very good. Any last advice? We have a minute left about this.
Well, if somebody has type 1 diabetes, the family has to understand it. Leave aside the child. They have to counsel their doctor, be in regular contact with their doctor, maintain their diaries, blood sugar diaries at home, and whenever they come to the doctor, they should make up a list. What happened last 10 days? How were the sugars? What our child ate? What was the calorie content? What was the carbohydrate content? So that the doctor will have a complete insight. Okay, and every 3 months they will monitor their glycosylate hemoglobin to see the progress of the disease. So it should be a complete connection between the patient and the doctor to get absolutely wonderful results.
Very good. Thank you so much. My dear viewers, Dr. Ejaz will be with us again next week talking about type 2 diabetes. We entertain your questions and comments. You can write me at Medicine Islam, P.O. Box 111, Sharjah, UAE, And you can also send me a fax at 9716-521-969, or you can contact us at a website, which is Medicine in Islam at sharjahtv.ae. And as our custom on Medicine in Islam, we'd like to conclude all of our programs with a short dua, a short prayer of the Prophet Muhammad, sallallahu alaihi wasallam, peace be upon him, such that if any errors and mistakes have been made on this program, and most importantly, if any sins have been committed on this program, that Allah subhanahu wa ta'ala in His infinite mercy and grace will forgive us. Subhanallah bihamdihi, subhanallahu bihamdika, wa nashhadu an la ilaha illa anta, nastaghfiruka wa natubu ilayk. Jazakumullahu khairan. May Allah reward you with the very best Islam. أعوذ بالله السميع العليم من الشيطان الرجيم من همزه ونفخه ونفسه بسم الله الرحمن الرحيم نحمده ونصلي على رسوله الكريم أما بعد. Welcome again, dear viewers, to Medicine and Islam, a program sponsored by Sharjah Television that features topics relevant both to the field of medicine as well as to the great religion of Islam. Alhamdulillah Rabbil Alameen. Last week we were talking about type 1 diabetes, and the title of that program was an introduction to type 1 diabetes, even though we had, presented several segments before then. And that was because we have our specialist with us now, Dr. Ejaz Yasmeen.
Assalamu alaikum.
Wa alaikum salam wa rahmatullahi wa barakatuhu, who is a specialist in both internal medicine and diabetology, which is a branch of endocrinology at BELHOUL Specialty Hospital in Dubai here in the Emirates. Welcome back, Dr. Ejaz.
Thank you.
Well, one comes before two and two comes before three. So last week we talked about type 1.
Yep.
So today we want to talk about type 2, which is, of course, the more common type of diabetes. Let's first begin with the definition. And in common, in lay terms, what is the definition of type 2?
See, the type 2 diabetes, in these patients what happens, there is a relative insulin deficiency compounded by the insulin resistance. What happens with obesity, other factors, the beta cells start decreasing their content of insulin, and subsequently whatever insulin is there, it's not able to penetrate in the tissues. So what happens in these patients are generally obese, they have an insulin resistance, and their beta cell mass is decreasing day by day. Okay. And when at a particular point of time, when a particular mass of beta cell is depleted, they manifest as diabetes.
Okay. Now, what causes the beta cells to diminish?
See, it depends upon the first and the foremost thing is the obesity. Okay.
Direct correlation?
Direct correlation, the obesity, lack of exercise, okay, there's a direct correlation, and some genetics. Definitely those patients who have a first degree or second degree relative who has a diabetes, they are high risk of getting type 2 diabetes in their future. Those patients who are overweight, who are obese, they have a chance to get type 2 diabetes. Those patients who have polycystic ovarian disease, they have a chance to get diabetes. So it is a compound, where all the genes play some role, some genetics, and on top of it, the obesity. It's mainly the obesity. If you see this part of the world, the obesity is pandemic.
Yes. Okay.
And the prevalence of diabetes is around 19%, as I told in the last episode. We are the second in the ranking. The only first is the one of small islands, which is called the Nauru Island. It's somewhere in Australia with a population of 50,000. So if we take that out, we are the leaders. Not only we, all 5 Gulf countries are leaders for the wrong reason. And the scenario is not changing. In 2020, we'll be still holding the fort of diabetes.
That's not something you want to be a leader in.
Yeah, definitely. We have to. That is why last year, this year was dedicated for the diabetes only.
Absolutely. Now, you mentioned this relationship between obesity and I've never heard it explained this way. I mean, I know that there was a correlation, but you say as obesity increases, the beta cells decrease in quantity?
Because it's a metabolic syndrome. Okay. In metabolic syndrome, what happens with passage of time, when the insulin resistance is there, you become more obese, less insulin goes in the tissues. Okay. It doesn't mean that type 2 diabetes does have insulin reserve. He has an insulin reserve, but this insulin reserve is not sufficient. Okay. You got my point? And in the first phase, there may be insulin levels may be even high. So in the first phase they may be high, with subsequent that they start decreasing, and ultimately the diabetes manifests.
Well, you've already partially answered the second question I was going to throw at you, which is why is there so much of an increase in this part of the world rapidly now? And you mentioned the obesity. And in connection to that, is there a way that you can actually decrease the insulin resistance? How do you do that?
If some people come from the Europe to Dubai, okay, they don't have, suppose somebody is from a country where the prevalence is very low. When he comes to Dubai, he has a high incidence of getting diabetes.
Why?
Because of the lifestyle. Okay. Whenever, if I had to go maybe to get something, I'll take a car. I won't use my legs. This is the reason. We don't do any manual work. We are always confined to our offices. We eat a lot of calories and we don't exercise.
Right.
It has been seen in one of the clinical trials, which is called the Diabetes Prevention Program, that if you do exercise, 35 minutes, 30 minutes a day, and you lose 5% of your weight, the chances of you, if you're a pre-diabetic, going into diabetes is decreased by 47%, much more than the drug used for pre-diabetes. So you can see, if you do the exercise, you modify your diet, the chances of you going to type 2 diabetes are very, very less.
Okay. I had a list of questions, but we're going to jump around and deal with them in order of importance. You mentioned something that rang a bell. You said the exercise of 30 minutes a day. I remember reading something from the American Diabetic Association about what was recommended for diabetics was about, 150 minutes per week or 30
minutes a day, 5 times a week. 2 days are yours.
Yeah, okay, yeah, 2 days you can rest.
Yeah.
So basically 30 minutes a day, 5
times a week. Okay.
Okay, this is a recommendation.
Yeah, you don't need to jog, you don't need to, just a brisk walk.
Brisk walk.
Okay, brisk walk means if you and me, we walk around 100 meters, at the end you feel a little breathless. That is a brisk walk.
Okay, that was my next question. What is your definition of a brisk walk?
Yeah.
Because different people have different definitions.
See, somebody comes to me, I'll jog from tomorrow, I'll run hard. That is not the way. You start slow and you start gaining up. Okay, so brisk walk means just a walk which will be brisk to make you breathless at the end of 100 meters.
Okay, because I was told about the breathlessness, and when my children walk with me, they don't get out of breath. I'm huffing and puffing and I can't breathe, and they're just strolling along like nothing's going on. And so it's not a brisk walk for them. For me, it's a very brisk walk.
Yeah, it depends on the age also.
Absolutely.
Okay, and on top of it, if you lose 7% of your body weight, suppose my BMI is 30 kgs, I'm obese, and I'm losing 7% of my body weight, my chances of going to diabetes are very less if I'm a pre-diabetic.
Okay. Now, my other question, and you're answering my questions before I can actually put the question in front of you, because your answers are so complete and comprehensive, and I appreciate that. Borderline, diabetes. My question was, what is your approach to them versus others? And you mentioned the exercise. That can stop it if you can catch them early, because prevention is always better than a pound of cure. So your first thing that you would do with the borderline diabetics is you get them on a
diet and exercise.
A diet and exercise.
There are no recommendations for any medicines as of now for a patient who has a borderline diabetes, unless he has both impaired fasting and impaired glucose tolerance, and he has a strong family history of diabetes and hypertension. Then you can put them on medication. Otherwise, only diet and exercise will do. So if a patient comes to us in the clinic, if somebody's blood sugar is more than 100 fasting, and less than 126,
they're in that category.
They is in the pre-diabetes. Or after eating, if the blood sugar is from 140 to 199, they are in the range of pre-diabetes. Or now they are using a new marker, the HbA1c, which is called the glycosylated hemoglobin. If it is between 5.7 to 6.4%, again is a pre-diabetes.
Really?
Yes. This is a new which was added in the ADA in the last session in January.
Because before they said normal was 4 to 6, but now they say up to 6.4, even is considered pre-diabetes.
Yes, from 5.7 to 6.4 is pre-diabetes. Above 6.5 is a diabetes. Now they don't use fasting. Even if you have HbA1c more than 6.5, you are a diabetic.
Regardless of what you
regardless of fasting and this. This is a new criteria.
This HbA1c is very powerful, very you can cheat your doctor, but you can't cheat that A1C, because it's going to tell you what's been going on for 3 months.
Yeah, unless if somebody has some hemoglobinopathy. Like in our people, we have a lot of thalassemias in UAE. So at that time, it is not a good marker.
Is that also true for people that have like sickle cell disease?
Yes, definitely. All hemoglobin, sickle cell, thalassemias, chronic renal failures. There will be some delineation.
Why chronic renal failure? Because of the erythropoietin?
Yeah. Because they don't get an erythropoietin, and the glycosylated hemoglobin will not be that great. But for hemoglobinopathies, it is definitely not a good marker.
It's not a good marker. Okay. Do you find in people with chronic renal failure that the A1C comes lower than it should be?
Yeah, definitely, but not that much. But it is mainly the marker for hemoglobinopathies like sickle cell and thalassemia.
Because the glycemic thing has to connect with the hemoglobin.
Because if you see, it is a glycosylated hemoglobin. The concentration of hemoglobin which binds with the glucose, and the half-life of RBC is around 3 months.
Right, 3
Okay.
months, right.
So that is what it gives us the details.
Very good. Now, there's a triad that most physicians and ADA talks about for type 2 diabetics. That is the triad of medication, diet, and exercise. Now, how important is that triad?
This triad is all important.
Okay.
Okay. You can't do only with medication. You can't do only with diet. You can't do only with exercise. They should complement each other. Okay. So if I have a diabetic who comes to me, I will start him first time also. I'll start him on medication, lifestyle modification, and his exercise. He has to avoid carbs from his daily routine.
Okay.
I don't say he has to avoid all carbs.
Right.
It should be still 40% of his total diet.
Okay.
Okay. So what do we do? Suppose a person is putting 3 spoons of sugar in the tea. He can just take it off, and if he feels, he can take an artificial sweetener.
Right.
If he's using a white bread or a milk bread, let him take the brown bread.
Right.
He can, if he uses his rice, okay, he can just boil the rice, take the water off, so that a lot of starch comes out. Okay.
Right.
Okay. And fruits, he can
And
take.
even now they have diabetic rice.
Yeah, definitely.
Absolutely.
Fruits and vegetables, fruits, they can take 4 to 5 servings. Okay. The general consensus in the public is don't take an apple. If you want to take an apple, take a green apple. Don't take a red apple. Okay. The thing is, regardless of this, they have to take 4 to 5 servings of fruit.
Now, regarding the carbs,
Yeah.
the juices are more dangerous than the fruits, aren't they? Fruit juices.
Fruit juices, definitely if it's concentrated juice, yes.
Yes.
Okay. If it's a homemade, you make a carrot juice, it's as good as a fruit.
Okay.
Those juices which have a low glycemic index,
Okay.
they're much better.
And definitely not the juices that have sugar in it.
Yeah.
You have to read and
Yeah,
check.
definitely.
Okay. Very good. So this triad is, it's like a synergism, isn't it?
Yeah.
They work together.
They work together. All the
Okay.
3 things work together. So you have a patient, advise him about his diet, his exercise, and on top of it, he has to be on medication.
SubhanAllah, very important. This is not always explained to the patients like that. Now, of course, this whole concept of certain the oral hypoglycemias, they don't all work the same.
No.
Some cause an increase in the release of insulin. Some cause a decrease in the resistance of insulin, like this and that. Now, this whole thing about glucophage and that family of medications is actually also being used for weight control and to lose weight. This has become a big thing in the West. Now, what is your experience with that? And because glucophage is great use.
All said and done, all agents used for type 2 diabetes cause weight gain except glucophage.
Cause weight gain.
Except glucophage.
Except glucophage.
And another new family which has come, which was in use in the UAE from the last 1 or 2 years, is the GLP-1 analogs and DPP-4 inhibitors.
And what are they called commonly?
They are called incretins.
Okay.
Okay, incretins. So what we do, glucophage per se does not act on the beta cells mainly.
Okay.
What it does, it decreases the production of glucose from the liver, okay, and promotes the movement of insulin in the peripheries.
Okay. Well, it has a different pathway.
Okay. Yeah, it's a different pathway. This medicine is a wonder medicine. It has stood time from last so many years, around 70, 60 years, and Americans were not using it.
Right.
Okay, because they're fearing it may cause some problem. Okay, glucophage has been used in America in the last 15, 16 years.
Okay.
Before that, it was not used.
Right.
And you will be amazed how it was discovered. It is not something medicinal, it's something herbal, if you're not knowing it. It was derived from a thing called professor's weed. What they did in UK, they found the cows who grazed on this grass, they used to sleep. And then when they found their blood sugars, it was very low. Okay, so this is how it was discovered, the glucophage, and this drug has stood time since long time. It's the most powerful drug. All committees, all associations recommend it to be the first line, along with diet modification, exercise. And after 3 months, if your HbA1c does not come to a desired level, you can put the add-on therapy.
You can add another.
Yeah.
Then another special quality of this glucophage is that at a certain point, it can make the blood sugar cut off when it starts to drop. You know, some of your oral hypoglycemia, like Dianol and others, they'll keep pushing it down.
This is not with the glucophage. This is with the newer drugs which have come. Okay, they work glucose-dependent pathway.
They will cut off.
Okay, once the sugars go down, the pump automatically shuts off.
Oh, that's very nice.
Okay, this is a new drug which has come in the market under the name of Januvia.
Januvia.
Januvia has come up in a big way. Okay, then we have the Galvus Okay. With combination with glucophage, it's called galvasmet or janomet.
Yeah, that's my question. Janomet.
Janomet.
Okay, because my wife takes that, and that's a combination.
It's a combination of glucophage and Januvia.
Okay.
Januvia does not deplete the beta cells. Okay,
Right.
it does not whip them like the other older drugs. Okay, whatever you need, it takes from it.
Okay.
And it acts on other cells also, the alpha cells.
Okay.
It also acts in the brain. It acts in the stomach. So it is a combo therapy, which is very good,
Very effective.
very effective in those patients who are drug naive, whom you catch earlier. And the most important thing is the hypoglycemia is very less.
And also with glucophage, with high doses, you tend to get a bit of nausea and side effects.
Yeah.
But with the Janomet, because it's a lower dose, you don't see that as well.
The only thing with glucophage is those patients who have a kidney disease.
Okay.
Okay, and the kidney is working around 30% or less. Okay. At that time, we should not give glucophage.
Okay, so it can be a bit nephrotoxic.
Yeah.
Okay.
30% it's working, you can give it. About 30% you have to be careful below 30%.
Okay, very good. Another question is, and we're just about out of time. Some patients with type 2 diabetes require a combination of oral hypoglycemics and insulin. And when does that? When do you have to make that decision, and how do you do that?
If you see that the sugars are not coming, the patient is on the maximal dose of oral hypoglycemics.
Okay.
It's a time when you say that the cells are failing, they need some support. So it is a time when your HbA1c is not coming down, you start them with an insulin, preferably a bedtime long-acting insulin.
Long-acting only.
To start with.
To start with, okay.
Yeah. To start with, and if it doesn't work, then the patient should be either on a twice insulin or 4 times insulin. We can take off the medicines.
Okay, so some patients can actually make that transition slowly by the combination. Some you have to just start the full-fledged insulin, and that doesn't work for everyone.
Yeah,
it's on a case-by-case.
Case-by-case, it depends upon their HbA1c.
Now, of course, we're out of time just about, but we've got to talk briefly about complications. What is your advice, and what do you look for?
The complications, what basically I want to stress to my patients, to the audience, that type 2 diabetes will affect you in the coming 10 to 20 years. Don't think the doctor is a fool, why to take medicine. It is just like a termite. If the termite takes the stable, the top will be perfectly all right. But when you put some weight on it, you will break down. So you have to be careful about your kidneys. You have to be careful about your eyes. You have to be careful about your legs, because diabetics are very prone to ulcers, and they can have, all the legs can get amputated. So we have to be very careful. These are the 3 complications which you have to look after: the eyes, the kidneys, and the nerves.
What about the heart?
Of course, diabetes is a cardiovascular risk equivalent. That means if we are here, God forbid, I had an MI before, and you have a diabetes. So your risk of getting MI is same as I have.
Okay.
You got my point?
I understand.
Yes. Yeah, so diabetes affects your heart also. So the thing is, you have to take care of all the complications to get a good result.
Okay, here again, time is out. This used to be called adult onset diabetes, but not anymore.
Not anymore.
Why?
Because now we can see type 2 diabetes in as young as 14 years of age, as young as 13 years of age, particularly in the African communities. I have seen patients who come to us who are 14, 15, and they are full-fledged type 2 diabetes.
Type 2, not type 1.
Not type 1. So now that concept is gone. To me, if I was a diabetologist, I will take this type 1 and type 2 off. I'll say diabetes.
Okay, I got you.
And I'll treat them full-fledged to get a good result.
Thank you so much, Dr. Ejaz. Now, this concludes our introduction to type 1 and type 2. After some time, we'll have you come back and talk in more detail about treatment, diagnosis, because there's always advancements. You got to keep us up to speed on this.
Right.
Thank you so much.
My pleasure.
Viewers, you can of course write us at Medicine and Islam, PO Box 111, Sharjah, UAE, or you can send us a fax at 9716-5311-969, or of course you can contact us through our website, which is Medicine and Islam at sharjatv.ae. We want to thank Dr. Ejaz Yasmeen, for coming along, and of course. We want to conclude this with a dua of the Prophet, peace be upon him, such that if any errors and mistakes, like his name, which I just did, have been committed, that Allah will forgive us and have mercy upon us. Subhanallah wa bihamdihi, subhanakallah wa bihamdika, wa nashhadu an la ilaha illa anta, nastaghfiruka wa natubu ilayk. Jazakumullahu khairan. May Allah reward you with the very best Islam.